Hello, we're going to be putting down an NG today. Certainly before we start, we need to have reviewed the orders and verified, educated our patient. We're going to ask him if he's had any nasal surgery, if he has any nasal occlusion on either side. If he does, if he says, well, you know, I can't breathe through my left nostril, then we say we're going to put it down the right. His concern will be, well, how am I going to breathe? He's going to become a mouth breather, so he'll be fine with that. We just have to do frequent oral care. Okay, so we're going to choose a Salem sump because this is going to be hooked to suction and going to be suctioning large particles through it. For an adult, we're going to put down a 16 to 18. We have a 14 here because that's all that fits in our mannequin. The Salem sump is a double lumen tube. Has an air vent on one side. Nothing goes into the air vent but air. Sometimes it needs to be irrigated if it gets secretions in it to clear it back out, so that it does have the air vent capability. It's also got holes, several holes down at the end of the tube to keep it from sucking up against the wall of the stomach, and of course then that's what the air vent is for. All right, so we have our suction set up, which we need to have obtained. One tube will go to the vacuum, and that'll be about an 18-inch piece that we'll be putting on there. There's another one that goes for the patient, and that's your 6 to 8 foot tubing that you want to get and put on there. There's another suction capability, like if you have a surgical drain that you want to put to suction, but we'll keep that capped off because we're not using that today. The large opening is for, like, say, once this has filled and we're going to take it to the dirty utility or whatever your facility wants you to do with the filled ones. We will first put some isolizer in it that will solidify the liquid so that it doesn't get spilled or anything. Okay, so it goes into our ring. The short piece then goes over to the suction setup. Hang on a second. And then generally you've got the regular suction, which is a continuous suction, intermittent, which helps again to keep it from sucking up against the wall of the stomach. So the first thing that I want to do is check my suction and see how high it's going to go up, and the way I do that is by putting my thumb over the tubing, occluding it. So I'm going to turn it on regular, occlude the tube, see how high the needle goes up. It should not go above 120. If it does, then I'm going to use this dial and dial it down some. Okay? So I've got it sitting on intermittent. I have occluded it, checked it, dial it to wherever the needle needs to be so it doesn't go above 120. And I'm going to leave it turned on and have it ready to use over here. I will put on some personal protective equipment, which I'm not going to do that right now, but generally you'll want a gown. The patient very often has emesis, and certainly you don't want to have to wear anything all day. You may want your fluid shield mask and, of course, your gloves. I've already determined I'm going to put this down the right nair. I need my lubricant, and this comes in a sterile package, but it's not a sterile procedure, although I'm going to keep it as clean as possible. But I'm going to open up my lube, squirt it out on my paper, and I also need to occlude my tubing. So I've got the little suction connector here. I'm going to take the air vent and put it over there. That occludes it. That way, you know, when I start putting this down, if the patient begins to have emesis, it won't come out the tube. Because if the end of the tube is laying over here at the bedside near me, it's going to drain down the side of the bed. So anyway, I need to do a measurement. little acronym for that is the NEX. So from the tip of the nose to the tip of the earlobe to the tip of the xiphoid, and then go down a couple more inches. And then you want to mark that with a piece of tape. Okay. I also want to tear a piece of tape ahead of time, so I'll cleanse the edge of this with alcohol. I want to tear a piece of tape, and basically it's going to look like a pair of pants. So I tear it down so far, leaving the end of it intact, so that I can put that on his nose. Okay, I'm going to explain to my patient that he needs to swallow. Once we get to the back of the nasopharynx, I'm going to have him put his head downward, and at that point I'm going to have him drink either some ice chips or just drink some water. And every time he swallows, that helps to allow the tube to go down more easily. And speaking of that, when you look at this mannequin, you can see how when he tilts his head forward, it's gonna allow it then to go straight on down. It will occlude like the opening into the lungs, so that it hopefully doesn't go down that way. Symptoms of it going down into the airway would be he would start to cough and become cyanotic, and if so, then I'm going to pull it back out till I get out of this area. I'm not going to pull it completely out, because then he has to go through all that discomfort of putting it down again. I need to lubricate the first 3 or 4 inches of it or so. I don't want to get my fingers in it so that it becomes slippery. Okay, so we're going to put the tube down. He has his bath pan rather than an emesis basin, because an emesis basin just isn't large enough for a procedure like this. Tell him to hold on to it. That way it hopefully eliminates him from pulling at my hands as I try to put it down. I've got his cup of water close by. I don't want to point this straight up as I go in. I'm basically pointing it back towards his ear. He has his head backwards, and I begin to put the tube down. And again, once I get to the back of the nasopharynx, it's difficult. I just have to push a little harder. It makes the curve. Once it makes the curve, then he puts his head down, and he's holding on to his cup and drinking his liquids, and I say swallow, swallow. If he begins to cough and turn blue, I'm going to pull it back because it's gone down his airway, and then reposition his head and push again. I'm going to keep going. Every time he swallows, I'm going to push it. And now if he starts to have emesis, I mean, honestly, you don't want to prolong the discomfort, just go ahead, tell him to hold on to his pan. And I'll continue. Okay, so I've removed my little piece of tape that marked my spot. I'm going to tape this in place. Move one side back, and it doesn't stick real well on him. But what I want to do then is curve my tape around the tube. Okay, and then I will take the other piece of tape. It's not sticking on him, I'm sorry. And curve it around the opposite way. I want to keep the tubing on the tape on the tubing, and I don't want to pull it back up on his nose, because if I did, it might cause a pinching of his nostril there, and I don't want to put any extra pressure onto his nostril. Once I've got this in place, I do need to check placement. I'll tell you that I'm going to show you the traditional way. Your book no longer includes this, but I'm going to show you this because many of the facilities around here still include it. And you'll have to go by your facility policy. So what I want to do is go to the epigastric area, go to the end of the xiphoid process, over to the left a little bit so that I'm over the fundus of the stomach. I have I'm going to put some air into my irrigation set. And I'm going to have my stethoscope in my ears, listening over the epigastric area, force the air in. I hear a bubbling sound if it's in the right place. It's, just air through liquid is what I hear through my stethoscope. And that's the traditional way. This is what your book no longer includes. But then what your book does tell you then is to aspirate for gastric contents. So I'm going to pull back, see if I get gastric contents. I am going to then, let me stick this back on there. I will check with some pH paper. This kind of paper is nitrazine and it does pH only. What you want is for it to be in the area, in the gold area. You're going for the gold. pH around 5.5 if it's gastric secretions. So I'll put a little bit on my paper and note if it turns to the gold color. If you don't have the nitrazine paper, there's the strips that come in a bottle, and you may use those. Every facility has one different. This one obviously tests for many different types of things. So we want pH only. Okay, so I have checked for placement. The other thing your book tells you is to obtain a chest x-ray. Of course, that is up to the physician or facility policy. Certainly a chest x-ray is definitive. If you get that chest x-ray, they tell you it's in the right place. As soon as he returns to his room, what you want to do is take a measure and measure from the tip of his nose to the end of the tubing and document that measurement. And then when you do your assessment each time, when you're verifying placement, then you can measure, and that is definitive also. Okay, so we're going to hook him to suction using the little connector. Okay, and connect him up, and he's good to go. Once it's in, I want to document the amount of secretions that I get returned initially, and then I'll mark it on the white area on here. This is marked off in milliliters, and I want to note exactly how much he had, and then leave my mark there, time it and date it, so that the next person that comes along then will know whatever output he's had until the next time. As far as caring for the tube, generally the physician will ask that you irrigate the tube. So you're going to have your irrigation set filled with either tap water, saline, or sterile water, depending if this patient's had like gastric surgery, just depending. So I've got verification that this is in the right place because I have measured, and also I'm getting gastric secretions out of it. I can open it up. I can check the pH as I open it. Again, if your facility policy says so, you will verify placement with air, listening over the epigastric area. So I'm going to pull up 30 milliliters of saline, flush it through the tube, pull back to try to get my irrigant returned. Sometimes it's difficult to get all of your irrigant returned. If you can't get it all, then you want to add that as intake. So we have to make sure that we're doing a very accurate I&O. Now, another problem that we often have is that the air vent will sometimes fill with secretions. And what happens is, it's not sticking very well, is the air vent fills with secretions if it drops below the level of the stomach. So we want to try to keep it up here at all times. Great. One thing that we'll do is to take a piece of tape. We want to secure this so it doesn't pull at his nose. So no matter what, always, we want to have secured it to his gown. Put a piece of tape around it, take a safety pin, and pin this to his gown so that it doesn't pull at his nose. But this also will kind of keep it up higher. But if you've got a patient that's sitting up, laying back, whatever, if he's very mobile, it's going to move around and this is going to dip down. One of the things there that we have is an anti-reflux valve somewhere that we can put in here. And see, this end is to the suction, but it won't stay. Sorry, guys. This goes into the air vent. This has a little piece of filter paper, and it's supposed to let the air flow, but at the same time stop the secretions from dripping out in case they come. But the problem is that filter paper can, once it gets wet with secretions, it can become clogged, and then basically you've lost the capability of the air vent. And so this is why many surgeons will not allow an anti-reflux valve to be used. But you'll see them here and there. And otherwise, you just got to try to keep this up above the level of his stomach at all times so it doesn't get a backflow of secretions. When it comes time to remove the tube, what we want to do is to, first of all, disconnect from suction and irrigate the tube. So I'm going to pull up some saline, push it down the tube. I first check placement before I put anything down the tube. So I irrigate it to remove the acidic secretions, and then I'm even going to follow it with air so that I know that my tube is dry. So I push some air behind it, and once I've done that, then I want to occlude the tube before I remove it. The risk is that he might aspirate as I remove the tube, so I have clamped the end of it so it doesn't have air, and then before I pull it out, I'm also going to pinch it off. So I've removed the tape. I have maybe paper towels, a towel, whatever, and I'm going to quickly do kind of a hand over hand motion, pull this thing out, get it out of his view because it's gross. And I have a place to put this. Put it in my trash can. And then I certainly want to have tissues so that he can blow his nose. We need to do oral and nasal care then for his comfort.